in England. So first of all, before I begin, I would like to thank everyone for making this happen, and quite a lot of people from different countries have essentially come together in making these sessions happen. So what I'm going to do is I'm going to talk to you about briefly about what these sessions are about, and then we'll start our first session. Has it moved on to the next slide?
No, it hasn't.
Now? Is it now?
Yeah.
Awesome. Okay. So what we have done is we have organized 6 sessions over a 3 months period. And the aim of these sessions is to give you an overview of dermatology. We feel that dermatology is one of those specialties which isn't covered very much in detail in medical education. And yet it's a condition that we very, very commonly encounter. And when I graduated, when I started working as a doctor, I realized that my ability to describe rashes and any dermatological condition was pretty poor. And many people struggle with it. So essentially what we are aiming to do is, to give you an overview of dermatology. And what we've done is we've created this timetable with different topics. So initially we'll start off by introduction to dermatology, what it's like to work as a dermatology trainee in the UK. And then we'll move on to further explore dermatology as a specialty, look into different subspecialties, which is in the branch of dermatology, like surgery, medical dermatology, psychological dermatology, and different subspecialties. And we have picked up a few common dermatological conditions which we are very likely to encounter in our life. So the condition we have picked up are like eczema, psoriasis, acne, skin malignancies, and we also do a topic on tropical skin conditions. And we have also chosen skin of color, which is quite a hot topic these days. As you guys are aware that, in our textbooks, we learn about how dermatological conditions present in a lighter skin color. And what we know is that in people who are deeply pigmented or have dark skin color, the conditions can present in a different way. And it's important to have a better understanding of that as well. So we have quite a wide variety of topics. And if you guys want us to cover anything else, do let us know. Okay. Now, to start off with introduction to dermatology, what I'm going to do is I'm going to talk to you about what dermatology is and principles of dermatology assessment. What that means is how to take a dermatology history and how to examine a patient who presents with a skin problem. So before we do that, I've got a mini quiz. I've put a link to it in the chat. Can you all see it? If you could go, if you can click on the link and do a mini quiz, that will be, I will be very grateful. It's just to see, it's nothing too serious. It's just to kind of see what your understanding of dermatology is as a specialty. Is that okay, guys? And what I'm going to do is I'm going to bring it up here. See your responses. Let's see. Can you all go to the link? Are you having any issues at all? Okay, we got 5 responsive. That's right. So, Luca, at the moment, what can you see on, because I'm still sharing my slides. Can you see the,
I can see your slides. No, I can't see the results.
Okay. Right. What I'll do is I'm going to talk about what people have responded. Is that okay? Because I don't know how to share these. It would have been nice.
You can try sharing your entire screen. I think that probably allow it.
My entire screen, because I'm on Google Forms right now.
Yeah, so if you stop sharing and then you hit share again, and instead of going to a window, just go to like the full screen.
Can you all see the?
Yes, we can.
Awesome, great, thank you. So, I came up with a few questions in this quiz, and we will be covering all these in today's talk. So the first one is, dermatology is a branch of medicine which deals with skin and hair, skin, hair and nail, skin, hair, nail, mucous membranes, or skin, hair, nail, mucous membranes, and soft tissues. Well done. The majority of you, well, actually, okay, so the majority of you have 75% have said skin, hair, nails, mucous membranes, and soft tissues, and 25% has said skin, hair, and nail. Okay, I will be going through the answers shortly. Second question was, skin is the second largest organ in the body. So 87.5% have disagreed with the statement, and 12.5 agreed. Okay. There are 1,500 distinct skin diseases. 100% agreed. Excellent. What percentage of people may suffer with dermatological problems? Interesting. So the majority of people went with 50 to 70%. That's good. That's good. And lastly, a macule is, so 75% of people have said small flat area of altered skin. Excellent. So what I'm going to do is we're going to stop sharing this and we'll go back to the slides. Okay, are we back onto the slides, guys?
Yep.
Awesome, great. So well done for doing the quiz, guys. We will be going through the answers now. Oh, it's doing that thing again. Let's see. Okay, so what is dermatology? Dermatology is a specialty that deals with skin, mucous membranes, hair, and nail. Now, I noted that majority of you went for skin, mucous membrane, hair, nail, and soft tissues. Soft tissues are things like muscles, tendons, and stuff. Dermatologists don't deal with that. It's mainly the skin, mucous membranes like your mouth, genital area, etc., your hair and nail. So that's, it's a branch of medicine dealing with a lot of things, because most people think that dermatology is just focused on skin, but no, there are other areas involved as well. Most of people very rightly got it right. Skin is the largest organ in the body, and because it's the largest organ, there are many different diseases, 1,500 distinct skin conditions. And I guess that's something that makes dermatology very interesting, in that, you can come across a rash which may look very similar to many different types of rashes. And, with your knowledge, your skills, ability to diagnose and treat, you'll be able to get to the bottom of it, like what exactly is the cause of the rash. Now, why is dermatology important? It's mainly considered an outpatient-based specialty. And if you look at the statistics on this slide, it accounts for 15% of general practice consultations or family medicine consultations, and about 50 to 75% of patients have skin problem, in their lifetime, which are quite high numbers if you think about it. But in majority of the cases, it's something small. It's not something that can make you quite unwell or require you to be hospitalized. However, having said that, people who do become unwell with dermatological complication, the prognosis or outlook can be pretty bad. Okay, any questions before I move on? No? Okay, so I'm going to talk about dermatology history. As you may all be aware of, how to take a standard history, we start off by exploring the patient's presenting complaint, which basically means what is the problem they have come in with. And in that, you need to gather, the nature of the problem, the site, where exactly is it, and duration, how long has it been there for. In terms of history of presenting complaint, that basically means you are, exploring further about the presentation. And the important factors, important questions to ask include evolution of lesion. So how did it start and how has it progressed? And associated factors, is there anything that makes it better? Anything that makes it worse? Have you tried anything at all? Or, is it related to stressful life events? Because certain conditions can be like psoriasis. Important to ask about their recent travel, their recent contacts. And particularly in cases of, if you're thinking about melanoma, is, if the history of sunbathing, going on holidays, working abroad, and using sunbeds, etc. So it's important to kind of narrow down, or to explore the risk factors associated with that particular type of condition. Moving on to the past medical history, important questions to ask in past medical history is if they have any history of atopy. So, for example, do you suffer from asthma, hay fever, etc., which may be relevant if you are thinking that patient may have eczema, and also any past history of any skin malignancy or any suspicious moles, etc., which they had removed in the past. Moving on to family history. Very important, because if a family member has been affected by a dermatological condition, that can increase the risk of having the condition as well. So it's important to explore that, and also in the cases of malignancy. Social history, occupation is very important. So really, you want to find out what their occupation is. How much the skin is in contact with whatever they are doing. Are they dealing with chemicals? Do they wear gloves? All these questions are relevant in the context of whatever skin problem they have presented with. And importantly, you need to ask them how their skin condition differs when they are at work or away from work. that may also give you an idea of, you know, how relevant it is to their presenting complaint. Moving on to medications and allergies.
Musfira,
Yeah.
sorry to interrupt. Just double checking. Can everyone see Musfira's screen? You can do a thumbs up if you can. Just double checking. Yeah, they can. That's just double checking. Sorry, thanks.
Awesome, great. Thank you, guys. Moving on to medications and allergies. Now, many medications are associated with rashes or skin problems. So it's important to explore that area. Any new medications, any medications over the counter. Now, patients don't always give you information of what sort of medications they may be having, let's say, buying online or over the counter. They might just give you a list of their prescribed medications. So it's important to explore that. And it's important to get a timeline with regards to that. Did the rash come on after you started the medication, and how long after did it come on, as an example? And very importantly, the impact it can cause or it has been having on the quality of life. Now, I think we kind of underestimate how much impact dermatological conditions can have on people's self-esteem or quality of life, their ability to socialize and go out and stuff. So it's an important question to ask. Any questions at all, guys, before we move on? Okay, so I'm going to talk about dermatological assessment. So how would you assess a patient if they come in with the skin lesion, skin problem? Like with any other examination, you will start off by inspecting the patient, from the bedside, just having a general look at them. And in that, one of the main things you want to notice is what their skin type is, how pigmented their skin is. And then identify the site or number of lesions. Sometimes what can happen is that a patient may be referred by their GP for a mole suspicious of melanoma. But it's important to kind of inspect the patient fully, because you might identify other moles which are also, look worrying. So next, moving on to, once you've identified where the problem is, you need to describe it. Now, I feel this is something that I personally struggle with as well. And I've seen my colleagues struggle with as well, the ability to describe a dermatological problem or dermatological lesion. So to kind of break it down, what you need to do is you need to talk about the size or shape of it, the color, and any associated changes. Morphology basically means the structure of a lesion, and I will talk about it in a bit more detail shortly. Now, if a lesion is pigmented, it is important to use the ABCDE as a guide to describing it. So I'm just going to briefly talk about the ABCDE. And what essentially it's used is if there is a mole, let's say, or lesion suspicious of melanoma, there are certain factors which are suggestive of the lesion being melanoma. So what A stands for is asymmetry. And what essentially means is if one half of the spot or mole or lesion looks different to the other half, as you can see in the picture. So that is more suggestive of it being melanoma. B is border. And what essentially means is that the border is irregular or is poorly defined. C stands for color. And if it has more than one color or different colors within the lesion, again, it is more suggestive of melanoma. D is the diameter. Now, diameter over 6 millimeter is suggestive of melanoma. And what they say is equal to a pencil eraser, size of pencil eraser. And hence in the picture, you can see the size. Having said that, people can present with moles suspicious of melanoma or melanomas which are smaller than 6 millimeters. So you need to take that into account as well. And lastly, evolution. How has the lesion changed or progressed over time period? Okay. So this ABCDE approach is something you use if you come across a lesion which is, or a mole which is suspicious of melanoma, or a pigmented lesion essentially. Okay, now that you have inspected the patient, you have described the primary lesion or primary pathology, the next thing you need to do is you need to palpate the lesion. You need to feel the surface. You need to check if it's mobile, if it's tender, you know, if it's warm to touch, or what the consistency is, to get a better idea what sort of lesion it is, you know, whether it is an abscess, you know, whether it's cellulitis with the temperature being raised, and it helps you further guide or narrow down the differentials. Lastly, systemic check is very important. And what that means is you are also looking at the hair, scalp, and mucous membranes. It is very important in dermatology to not just focus on that one lesion the patient has presented with, but to fully examine the patient. So for example, let's talk about psoriasis. Psoriasis can also affect, you know, back of your ears, your scalp, your sacral region, you know, your belly button region. So it's important to examine those areas. And also, let's say if a person has presented with a suspicious mole, again, it's very important to do a full body examinations, because like I mentioned before, you might find other moles which are suspicious of melanoma or other skin cancers. So it's important to do a full body examination. Okay. So that's how you do a dermatological examination if somebody presents with a skin lesion or skin problem. I'm now going to move on and briefly talk about how to describe a structure of lesions. Before I do that, do you guys have any questions? Or you can post it in the chat if you don't want to say it. We'll pick it up.
There's no questions currently. Yeah.
Okay, cool. Keep me posted, Luca. Thank you. Morphology. Morphology, like I said, it describes the structure of the lesion. So, macule. This was also a question in the quiz. What is a macule? Macule is basically a small flat area with a small flat area of color change, and it's not elevated. It's basically flat. Is anyone able to give me an example of a macule? I'll bring one up here. Does anyone know what this is? What has this lady got? Anyone want to post it in the chat?
I can say it. It's freckles.
Excellent. Yeah, freckles. Well done. Well done. So patch. Patch is a larger area of skin change, and it has a smooth surface. So an example of patch would be this. Does anyone know what this is? What has this lady got? Vitiligo. Vitiligo. Okay, it's an autoimmune condition. Fine. Okay, moving on. Papule. Papule is solid elevation, which is less than 0.5 centimeter in diameter. An example of a papule will be this. It's slightly tricky, but and does anyone want to have a guess of what that is? It's basically xanthomata, which is accumulation of fat. Okay, and a nodule. Nodule is similar to a papule, but it's a bigger form. Over 0.5 centimeter in diameter, and it extends deeper into the dermis than a papule. And an example is here. And okay, I've covered plaque as well. And plaque is a palpable raised lesion over 0.5 centimeter in diameter. And example here, psoriasis. Vesicle is raised, clear fluid filled lesion, which is less than 0.5 centimeter. And you can see a picture here of shingles or herpes zoster. Bulla is a bigger form of vesicle, which is over 0.5 centimeter in diameter. And you can see bullas with burns, etc. And a pustule is basically a vesicle, but it contains pus, which you can see in acne. Okay, so this is, so little bit on morphology of lesions. It can be quite tricky. It's difficult to remember what is a macule, what is a papule, etc. But what I was hoping to do is, describe a lesion. Would anyone like to describe this for me? You don't have to do the whole thing, but just, a few points of how would we describe it? Anyone, what do you think it is? What do you think? Is it a papule? Is it a macule? Is it a nodule, a vesicle? So it's round. It seems to be over 0.5 centimeter. It's elevated.
Someone's saying a nodule on the chat.
Oh, good. Well done. Yeah. So excellent. It is a nodule. Well done. So we can start off by identifying the site. So it's on a hand. It's on a dorsal aspect of the hand. There is a nodule, and if you see on the top of the nodule, it's quite crusty or scabby. And if you look at the bottom of it, there is a bit of pigmented skin. So you can say there is a nodule on dorsal aspect of the hand, and it has a scabby or crusty surface. Okay, and underneath the nodule, there is a bit of skin pigmentation. So what I feel helps is if you break it down. So you will start off by the site of the lesion, and then you describe what the lesion looks like. So it helps with that. It helps to kind of break it down and present your findings essentially. Any questions before we move on, guys?
What is that though? I don't know what that is.
Yes, it's called, oh gosh, why I have wait, hang on a second. I can't believe the name has just gone out of my head. Gaurav, help me out here. It can look in a similar form as
so it's either an SCC or a keratoacanthoma.
Keratoacanthoma. So now it can look quite similar to an SCC, squamous cell carcinoma. And what we normally do is we get it removed and view the histology of what exactly it is. But this picture is of keratoacanthoma. So it presents as it can grow quite rapidly, and it presents like a nodule with crusty top or scabby top. Thank you, Gaurav.
I remember med school that the show is a similar one, but they used to always show a picture of someone in their forehead, and we tend to like associate it to the forehead, but I never saw it in the hand, so that's a good thing to know.
Yeah, so it's more common in sun-exposed areas, and it tends to occur in people in older ages. But yeah, the squamous cell carcinoma is a very important differential in this case, and ideally you will need to have the lesion removed. Okay, any questions at all? So I've finished the introduction of dermatology. I'm going to move on and briefly talk about life as a dermatology SHO. Nope. Okay.
No questions in the chat.
So life as a dermatology senior house officer or a residency, Essentially, what I'm going to do is I'm going to talk about a little bit about the pathway of what happens when you post-graduation. So you do 5 years of medical studies here, and then you graduate, happy days. And post-graduation, you do foundation program, which is basically you work for 1 to 2 years. And then you apply for training. And in my case, I apply for internal medical training, which is about 1 to 2 years, can be 3 years long as well. After that, you apply for specialist training. So specialist training in whatever area. In our case, we're talking about dermatology. And then you spend at least 4 years in training before you become a dermatology consultant. So that's what the pathway is. So I am going to give you a perspective of working as a dermatology internal medical trainee. So I worked in tertiary in a big dermatology center for 4 months as a part of my training. And with regards to things you have to do and things you get to do, as a dermatology trainee of my level, you have to do medical on calls, which means that you don't cover dermatology on calls, but medical ones. You are clerking in patients, you reviewing sick patients on the wards, you do weekends, twilights, and nights. And with regards to your job as a dermatology junior, you get to see patients who have been referred by different teams with any sort of dermatological issue. And you also review patients who are under dermatology on a daily basis. Okay. In addition to that, there are several things which you can do. You can attend clinics. And because I worked in a tertiary center and they're like experts in dermatology, there were lots of different types of clinics available. So psoriasis, eczema, skin cancer, etc. So you get a wide variety of clinics you can attend. In addition to that, you can also attend theaters where you can practice your skills, taking punch biopsies or suturing or doing incision biopsies. And in addition to that, you can do further skills, for example, taking swabs or applying dressings and creams, etc. on patients. So there's a lot you can do and be a part of. In terms of a typical week, this is what a typical week looks like for a dermatology junior. As you can see, most of the days you do ward round. And what I really liked about working in dermatology was that you get to do ward round by yourselves. And if you have any questions or any queries, concerns, you can always discuss with your seniors, and there's a lot of senior support available. Ghaurav was my registrar when I was working, very, very kind and helpful. So it's always nice, to be able to see patients, make decisions, or come up with a management plan, but obviously run those past your seniors. Mainly in morning, you do ward rounds. It's either by yourself or consultant or a registrar led. And in the afternoon, you do your ward jobs. You can attend clinic. You have allocated time for teaching as well once every week, and you can attend theaters, procedures, etc. Okay, so that's what a typical week looks like. What I enjoyed about my rotation in dermatology in a big specialist center was that you get to see a lot of cool stuff. Now, my knowledge of dermatology before starting the placement was pretty rubbish. It still isn't great, but I got to learn a lot and I got to see a lot. And you get to appreciate the complexity of the disease, because you get to see a variety of different skin conditions, and it makes you wonder. It's very tricky to be able to differentiate within different skin conditions. Like we talked about, there are like 1,500 different skin conditions, and it's important, you know, for you to be able to differentiate or have an idea. So you get to see a lot, and the more you see, the better you get at identifying things. The other thing I really enjoyed was that people can be very complex. When they are unwell, they can be very unwell, and you need to have input from different specialties. So, you know, they can have problems with their eyes, or, you know, for example, if the mucosa is involved, they have lesions in their mouth, you want to get the oral surgeons involved. If they have lesions in the genital areas, you want to get the urologists involved. So you get input from a wide variety of other specialties. And very importantly, you get to appreciate the psychological aspects associated with dermatology as well. And, you know, because like we talked about, it can have a massive, massive impact on people's psychological well-being. So yeah, that's the stuff I enjoyed about it. How a little bit about, you know, what you need to do to get into dermatology. I guess you got to build a dermatology portfolio, and how you need to do that. You know, you need to keep a track of the clinics you have attended, the patients you've seen, the theaters you have been to. Essentially, what you need to do is you need to show your commitment and interest to this specialty. And how you do that is by, you know, doing these things, attending conferences, doing projects, audits, quality improvement projects, teaching others, and getting some publications as well. Okay, so my talk finishes here. Does anyone have any questions before I pass on to Ghaurav?
So they do have a question. One was, so we need to work 1 year +2 of internal medicine plus for dermatology. Is that correct? So just to clarify, when you qualify from Honduras, you've done your foundation already, basically. So as soon as you get your GMC license, you could pretty much apply straight to internal medicine. If you get in, you get in. If you don't get in, then you could work in something else as a clinical fellow in the meantime, and then apply again for internal medicine. Do 2 years and then reapply for dermatology training. And as Musfira was saying, those are the things you need to look out for to trying to build a new portfolio. Any other questions, guys?
Yeah, I think one of the things I would suggest is it's better to start building your portfolio from an early stage. It just so you have a lot of things to talk about when you have your interviews and stuff. Yeah.
Let me see if there's another question. Any other questions? Not at the moment. I'll let you know if there's other questions.
Great. I'll stop sharing. Ghaurav, do you want to bring? I'll put up your slide. I'll stop sharing, right? Yeah.
Yes.
I'm pretty bad with technology, guys. Sorry.
I'm just going to have to log out and log back in to share my screen. Just give me 1 minute.
That's okay.
So while Ghaurav is doing that, I can't remember whether I posted. No, I haven't. So what I'm going to do is, guys, I'm going to post a link for feedback on this session in the chat. Once Ghaurav has given his presentation, I will be grateful if you can fill that in. And like I said, if you have any more ideas, if there are any topics you would like us to cover, do let us know. Okay. Where did I put that link?
So out of curiosity, there we go, it's coming. Is anyone in the session considering to come to UK for dermatology? Because if you are, you probably want to be best friends with Musfira.
Ghaurav. And everybody.
Yeah, there we go. Laura Velasquez is. So there you go.
Okay. Can everyone see that?
Yep.
Okay, so good morning or good afternoon, everybody. So this is just a brief talk on life as a dermatology trainee in the UK. So a little bit of background about myself. I did my undergraduate medical training at the University of Nottingham which is in the Midlands. And then I've done my membership exams for the Royal College of Physicians, and then the specialty certificate examination in dermatology, which you need to complete your training and become a consultant. This is just a photo of the Trent Building at University of Nottingham across from the lake. It's a very beautiful campus style university. Highly recommend it. Previous jobs, I know Musfira covered this briefly in her talk as well, but I did my foundation training in the East Midlands, where I did my medical degree, and that's the equivalent of an intern in the US, but it's 2 years long. And then you do a more, and that's kind of, you do, it could be anything: surgery, anesthesia, medicine, general practice, and that's for 2 years. And then you, at that point, specialize further into either medicine, anesthesia, surgery, whatever you prefer. The medical training route is 2 years long. And again, I did that in the same place in the East Midlands. And then for 2.5 years, I worked as a clinical fellow in dermatology, which is kind of like a non-training grade resident or registrar, as well as a clinical research fellow, working on some clinical trials. And then in 2019, I started my specialty training in the Northwestern Deanery, which is based in Manchester. So this is just a photo on the top of the Royal Victoria Infirmary in Newcastle, and the bottom one is the Salford Royal, where I'm working at the moment in Manchester. Again, I know Musfira covered this, so I won't go into it in too much detail, but essentially you do 2 years of foundation training, followed by a further 2 years of what's now called intermediate medical training, where you're essentially a senior, a house officer, SHO, or maybe a junior resident in the US. And there you're expected to do the first part of the MRCP exam, which has 3 parts. And then you apply for your specialty training, which for dermatology is 4 years long. And during that time, you're expected to complete your MRCP prior to starting your specialist training or soon after starting it. And then you're expected to complete your specialty certificate exam. Normally people do it in the penultimate year of their training, but you can do it at any point. And then you CCT, so you get your certificate of completion of training, and then you can work as a consultant, or you can do further post CCT specialist fellowship, depending on what you want to do. It's quite competitive, the interview process. There are very limited training posts available nationally every year, normally between 30 and 50. So in the last couple of rounds, the competition ratios have been, between 6 and 8 to 1. It's a 4-year training program, which is quite short compared to some of the most other training programs in the UK, which are 5 or 6 years long. But there is an option, depending on what specialty you want to go into. If you want to be a Mohs surgeon or specialize in pediatrics, there are various post-CCT 1-year standalone fellowships that are accredited by the Royal College. Approximately 250 trainees across the UK in total, so it's a relatively small specialty. There's around 600 consultants nationally, so it's a relatively small specialty. You can access the national training. I won't go into detail about it, but to know exactly what the training involves, you can access the curriculum via this website, and that's got all the information about the application and the process to getting into the training program there as well. So in a typical week, you'll do five clinics. You'll have at least 2 or 3 general clinics, which is a mixture of 2-week wait patients and general dermatology. So, like in this country, I think probably the mix of patients is probably different to what you have in Honduras. We see a lot of skin cancers in type 1 and 2 skin. We see a lot of inflammatory disease, a lot of immunobullous disease, not so much in terms of cutaneous infections. Hardly see tropical diseases and cutaneous infections. And then depending on what what rotation you're doing in your training. You'll have some subspecialty clinics every week as well. So I'm currently doing pediatrics. So I've got 2 pediatrics clinics per week, or you may be doing patch testing, or there are various subspecialties. You'll have some subspecialty clinics in your week as well. We also do minor ops. So there's 2 theatre lists a week, usually 1 independent and 1 supervised. So we'll do simple excision of skin lesions, such as that thing on that guy, on the back of that guy's hand. We would excise something like that. We can do various types of biopsies and other types of surgery to remove skin lesions, benign and cancerous. Then there's 2 sessions a week. SPA stands for, I can't remember now, but basically it's for audit and research. And then we have 1 afternoon of regional teaching per week. We do on-calls as well, which is, for here, it's 1 in 4, which is quite frequent compared to other places. We do a 9 to 5 shift of the weekend, no night shifts. We do have an inpatient ward at Salford Royal. Not every dermatology department will. So we can admit patients, and we see patients from all over the region with acute dermatological problems. So that is my talk. That's my email address. If anybody wants to send me, I'm happy to answer any questions now, but if anyone doesn't want to ask them now or wants to contact me later, that's my email address as well. So I'm happy to take any questions.
Check the chat. There's no questions at the moment. I think one of the things that would potentially be helpful for people that want to try to get into dermatology training, would you recommend, and would you say there's like secret to getting into dermatology training, or is there like a specific way that you prepare that you feel that was really successful for you?
Yeah, that's a good question. No, there isn't a secret. You just have to, if you know early in your career that's what you want to do, you have to basically, it's like an exam. You have to prepare to the curriculum, right? And in this case, the curriculum is the person specification, which is on the website. They very clearly list out, these are the things we want you to do. These are how many points. It's a point-based system. These are how many points you get for each thing. So you can prepare for it. And in preparation for it, you don't necessarily have to, you have to, do an audit, for instance, but it doesn't have to necessarily be in dermatology. It can be in something else. It's a transferable skill. So as long as you're getting all the things on the person specification and getting the things with the points, that's the main thing. And then preparing for the interview, again, it's a station-based, very methodical interview. It's not a kind of a chat with somebody. There's different stations, and you can prepare for that. There are courses for that, so you just have to put the time in. There's no secret. You just have to prepare for it like you would your exams.
Oh, that's great. Yes, we do have Laura Velasquez and Anna Sophia as well. She's planning to come to UK and will pursue a career in dermatology. So there you go, guys. You have his email address as well. So if you want to send him an email and ask him more questions about the process, I think he'll be happy to answer. Same as Musfira. If you can leave your email on the chat box as well, Musfira, if you want people to contact you. And I'm just gonna give you guys a little moment if you have any questions. Maria, Carla, Laura, Scarlett.
Actually, yeah, we'd like to ask a question that I feel would help others as well. Ghaurav, how do you feel about your clinical research fellowship in dermatology? How do you feel about it? Did it really help on your pathway to get into dermatology, or how do you feel about it? Yeah, basically.
Yeah, it's a good question. So dermatology is a very academic specialty. The research is very active in a lot of fields. You may or not have, but you probably heard of all the drugs that are coming out to treat psoriasis and eczema, and more is being understood every day. I did the clinical research job mainly because I didn't get a number. I had to apply a couple of times. So there are lots of non-training jobs that you can go for, clinical fellow jobs where you're working basically as a registrar clinical research jobs, there's a lot of those as well. I find it really helpful. It was a lab-based and clinical trials that I was working on. And you get a lot of the skills and that you need to flourish as a dermatologist, and you get you get the things that you need for your application as well. So publications, audits, you've got time to do those kind of things as well, because you're not in full-time clinical work. So I really enjoyed it, and I'd highly recommend it. But the thing is, with research, it's not for everybody. It is a different skill set from clinical medicine. So I wouldn't say you necessarily need to do, a research job or a higher degree, an MD or a PhD. But certainly, if you're at the stage where you're thinking about applying for a dermatology number, it will allow you to get a lot of the things that you do need for your application and develop a lot of the skills that will stand you in good stead as a trainee and a consultant.
Perfect. Thank you.
There's another question from Laura Valentina. She's asking about the quality of life during training. And just to give you a bit of a context, in Honduras, training, especially postgraduate training, we usually tend to do Monday to Sunday. We do over 80 hours a week, and you're always on call. You're only off 1 month a year. You don't have weekends off. So it's pretty much like the US. So that's why they want to know what the training life is. So.
Yeah, so it's very different from the US. So I know in the US, it's a 3-year program. You work 70 to 80 hours. It's quite intense. It's completely different in the UK. And I think part of that is it's a cultural difference. You're maximum going to be working maybe in our specialty, because it's mainly sessional and mainly outpatient based. So you're mainly just doing outpatient clinics. You do some ward-based activity if you've got a ward in your hospital, but typical day is 9 to 5. You don't do nights. You do the occasional weekend. Some places you cover overnight, but that'll be from home. You take phone calls from home. So a typical week is good in terms of hours. You get your weekends, you get your bank holidays, you get 30 odd days of annual leave a year. So the lifestyle is great, particularly so in the UK, about 3/4, so about of the 250-ish trainees that we've got, about 200 are women. It's very good for if you're planning a family. It's a short training program as well, so there's a lot of positives in terms of the work-life balance.
And additionally, you can do less than full-time as well if you want.
Yeah, of course. Yeah, you can do less than full-time, 50% less than full-time, 60%, 80%, whatever works for you. Yeah.
So just for you to be aware, Laura, less than full-time basically means that you don't do, like, let's say if you have 48 hours a week, you will do 50, that'll be 24 hours a week. But your training will be a bit longer just because you're doing less time. But those are options that you actually have in case you need like more time to do whatever, really. Let's see if we have other questions. So Musfira, maybe you would probably add about work-life balance as an IMT, because that's part of the whole pathway. Musfira, are you there?
Yeah, it's actually not too bad. I guess, so how it works is your normal job is 9 till 5, but then you have these on-call commitments. So you do nights, you do weekends and twilight. So we work in 1 in 3 or 1 in 4 weekends. So not too bad. But I do feel that as an internal medical trainee, it's slightly more intense than when you become specialist or specialist trainee. But I do agree with Gaurav. When you get into specialty training, it's quite nice because you don't do nights, and in weekends you're only working 9 to 5. But as an internal medical trainee, you do long shifts, like about 12 to 12 and a half hour long shifts as well. Mm-hmm.
All right. Well, that's great. So actually, internal medicine is not as bad as we're doing in Honduras, so you'll love it here. If you don't have any other further questions, I think that'll be the end of today's session. Thank you, Musfira. Gaurav had to leave. Yes.
Yeah, can I just ask everybody to complete the feedback?
Oh,
I
yes.
sent the link. I posted the link. If you guys can do that, that will be
And just
helpful.
copy it and paste it again so you can see it, guys.
And do let us know whether there are any topics or any areas you would like us to cover in the future sessions.
Great. So don't forget to fill out the form. And what we'll do is, the whole idea is that we have the sessions over around 3 months. And if you attend 80% of them, which is, I think, 4 of them, roughly, then you should be entitled for a certificate at the end, which will be really helpful for you if you're planning to come to the UK to do some training in dermatology, because this shows in commitment to specialty. So, so hopefully that should be helpful for you guys. And we'll have the next section on the 24th of September. So we'll be posting on social media. Also, the teaching itself will be available on YouTube as well. So in case you guys missed it, you'll be able to see it. If you have no other questions, speak now or forever with your breath. And don't forget to fill out the feedback form. Thank you, Musfira. Thank you, Anna. Thank you, Christina. Thank you guys.
Bye.
Yep. All right.